Hello, and welcome to the Tele Stroke Skills Checkoff presentation. I'm Kathleen, one of the 5 stroke coordinators here at UC Davis. The objectives we'll be covering in this presentation include the following. We'll talk about the goal of the Tele Stroke Skills Checkoffs, which is to ensure the consistency and training for all stroke specialty Tele nurses. We'll do this by establishing the basics of strokes, including types, etiology, treatments, and complications. We will review when and how to activate a stroke response at UC Davis. We'll also review Joint Commission requirements, ensuring standard of care and safety for our stroke patients. After you complete this lecture, you will complete stations at your skills day in January that will cover the documentation of stroke patient education, neuro assessment basics, and the NIHSS. First, let's start with the basics of stroke. We'll talk about types, prevalence, interventions, complications, mimics, signs and symptoms, and how to activate a stroke emergency response for these signs and symptoms. There are 2 main types of strokes, ischemic and hemorrhagic. Ischemic strokes are where there is an interruption in blood supply to the brain due to a blockage in the artery. 87% of strokes in the adult population are ischemic strokes. Hemorrhagic strokes occur when an artery ruptures in the brain and the blood leaks out, either into the brain tissue, ventricles, or the subarachnoid space. Hemorrhagic strokes in the adult population are the minority at only 13%. Hemorrhagic strokes can be further divided into 2 categories, intracerebral or intraparenchymal hemorrhage, which is where the blood leaks onto the brain tissue. The second is subarachnoid hemorrhage, where there is blood in the subarachnoid space. In ischemic strokes, there is an arterial blockage that can be caused primarily by plaque from high cholesterol, a clot from things like atrial fibrillation, if patients are off anticoagulation or not diagnosed yet, or a combination of the 2. Tests that you would expect for these types of stroke patients include a lipid panel, telemetry monitoring, and an echocardiogram. The lipid panel will assess the LDL level, which is the kind of plaque that builds up on the blood vessel walls. Telemetry will help to evaluate for atrial fibrillation, either sustained or paroxysmal, where somebody goes in and out of the AFib rhythm. An echocardiogram will help to evaluate for a patent foramen ovale, or PFO, which is present in about 25% of the general population. In patients who do have a PFO on echocardiogram, a clot from a DVT or from the venous system of the body could cross from the right to the left side of the heart and be pumped out of the left ventricle into the arterial system, leading to a stroke or heart attack. Patients with a positive PFO can expect to have a lower extremity ultrasound to evaluate for deep vein thrombosis, or DVT. This is most important because it may change their stroke prevention medications. Instead of being on aspirin or Plavix, they may transition to anticoagulation. There are times when the cause of the stroke may not be known or require additional testing, such as hypercoagulable workup, to see if there's underlying coagulopathies, making the patient more likely to form a clot. In ischemic stroke, the longer the artery in the brain is blocked, the more brain tissue becomes permanently damaged, which is why we really emphasize that time is brain. In an acute stroke evaluation, providers are assessing patients to determine if the signs and symptoms correlate to a specific blood vessel that's blocked in the brain. This is known as stroke localization. For example, in someone where the left middle cerebral artery is blocked, you may expect to find right-sided weakness, right-sided numbness, a left gaze preference or deviation, aphasia, either expressive or receptive types, or both, right facial droop, and right visual field cut. In hemorrhagic strokes, the artery in the brain bursts or ruptures, where blood leaks out onto the brain tissue or in the subarachnoid space, as we talked about on the last slide. Common etiologies of hemorrhagic stroke include hypertension, recreational drug use, anticoagulation, tumors, cerebral amyloid angiopathy, thrombocytopenia, and vascular malformations, such as arteriovenous malformations, also known as AVMs, or aneurysms. Hemorrhagic strokes are also a stroke emergency. Rapid recognition and intervention is needed to help give these patients the best chance at a good outcome. For ischemic strokes, there are three main types of intervention. There's thrombolytic medication, such as tenecteplase or TNK, mechanical thrombectomy, and medical management. These interventions can be done alone or in combination with others. TNK is a clot-busting medication that can be offered to patients with a last known well time of less than 4.5 hours. These patients also need to meet other inclusion-exclusion criteria as well. The last known well time, or the last time that the patient was seen without symptoms, is critical in decision-making for TNK eligibility. This is why we strongly recommend that a bedside neuroassessment is completed with the oncoming and offgoing nurses at shift change. This way, if there are any neurologic changes seen at that time, they can be immediately addressed with the offgoing nurse, who can provide some context and last known well, instead of having to comb through the EPIC flow sheets and notes from the night before, maybe many hours or a couple hours later. Patients who receive TNK will be transferred to the ICU for an initial 24 hours at minimum. The next intervention we'll talk about for ischemic strokes includes thrombectomy, or mechanical endovascular revascularization, also abbreviated as MER or MER. This can be offered to patients with a last known well time of less than 24 hours who have a large vessel occlusion identified on CT angiogram. Large vessels in the brain include the vertebral arteries, basilar artery, internal carotid arteries, and middle cerebral arteries. These patients will also go to the ICU immediately post-procedure. Patients who get TNK can also be a candidate to get a mechanical thrombectomy if they have a large vessel occlusion. The third type of management for ischemic stroke patients includes medical management. This will include multiple medications and other interventions, including orders for something called permissive hypertension. This is where, in the acute stroke within the first 24 to 48 hours, the physicians will allow the blood pressure to be higher, giving collateral blood flow to perfuse areas of the brain cut off by that occluded vessel. After the 24 to 48 hours, antihypertensives may be initiated to bring the patient back down to a more normal blood pressure range, with the long-term goal of normalizing the blood pressure to less than 130/80. This is the goal that we use to teach stroke patients how to help prevent another stroke, keeping that blood pressure less than 130/80. Antithrombotic medications include either antiplatelets and/or anticoagulation, depending on many factors, including their personal risk factors, medical history, their past medications, any recent procedures, and any new diagnoses. The last interventions for ischemic stroke include surgical interventions like decompressive hemicraniectomy or suboccipital craniectomy. These are indicated in patients that have swelling or hemorrhagic transformation post-ischemic stroke. In hemorrhagic strokes, there are both surgical and medical treatments for these patients too. Surgical interventions include decompressive hemicraniectomy, suboccipital craniectomy, securing a ruptured aneurysm with a coiling, clipping, or stenting device, microsurgery to remove some of the hemorrhage, external ventricular drains, also known as EVDs, or lumbar drains, or both, to monitor ICP and control hydrocephalus. Medical management interventions for hemorrhagic stroke patients will include blood pressure control and reversal of anticoagulation. Note the differences here on the slide for management of blood pressures in intracerebral hemorrhages versus subarachnoid hemorrhages in the acute period of stroke management. These patients will also receive repeat head CTs until the bleeding is noted to be stable, and then repeat imaging will be obtained as needed. What types of complications might you see in each of these types of strokes? Ischemic strokes can sometimes hemorrhage into the infarcted brain tissue, potentially causing worsened BFAST signs and symptoms, with or without a sudden onset severe headache that includes nausea, vomiting, and/or hypertension. Other complications for ischemic stroke patients include re-occlusion of the vessel, causing the original stroke signs and symptoms, or occlusion of a new vessel, causing new BFAST signs and symptoms. Ischemic stroke patients may also experience swelling or edema of the infarcted brain tissue. Edema typically peaks at 3 to 5 days after stroke. It can be managed with medications like 3% or mannitol and surgical interventions including decompressive or suboccipital hemicraniectomy. As an important aside, TIAs or transient ischemic attacks, often referred to as mini strokes, are warning signs for ischemic stroke. These patients are at high risk to have a stroke soon after the TIA. Monitoring these admitted patients and educating them on BFAST signs and symptoms so that they can call for help while admitted to the hospital or at home is crucial for their timely treatment. We'll go into TIAs a little more on the next slide. For hemorrhagic strokes, edema management can also be done with medications such as 3% and mannitol, as well as surgical treatments such as the decompressive or suboccipital hemicraniectomies. Additional complications in hemorrhagic strokes include seizures and hydrocephalus, potentially requiring an external ventricular drain or EVD or a lumbar drain. In subarachnoid hemorrhage, an additional complication is vasospasm. This is where the artery spasms down and cuts off blood flow, oxygen, and nutrients to the brain. This results in delayed cerebral ischemia and will present as BFAST signs and symptoms. You can think of this similarly to an ischemic stroke where the oxygen and nutrients are cut off to the brain, leading to those sudden onset BFAST signs and symptoms. The difference with vasospasm is instead of a blockage, the spasming of the artery is what cuts off the blood flow, leading to those BFAST signs and symptoms. One thing that's important to note as well are transient ischemic attacks, or TIAs. These are commonly referred to as mini strokes, and they occur when there's a temporary blockage in the blood vessel in the brain, leading to temporary BFAST signs and symptoms, which completely resolve within minutes to hours. In a TIA, there will not be any permanent damage left on the brain, which we can see on MRI. TIAs are important because they can be a warning sign of a future stroke. It's important to complete the full stroke workup and attempt to identify modifiable risk factors for these patients in order to help prevent a future stroke or a repeat TIA. Educating your patients on BFAST signs and symptoms, as well as their modifiable risk factors, will be critical to helping them prevent a stroke in the future. As of note, it's very important for shift change on these patients to identify whether or not they're having any current neurologic signs and symptoms. If their current neurologic status is totally within normal limits, then their last time that they're known well is right now. Whereas if they have any residual signs and symptoms, such as facial droop, weakness in a hand or arm, that last known well time will be different, and it will be the time that they were last seen totally normal without those weakness signs and symptoms. Some other diagnoses can also resemble stroke signs and symptoms. It's important to understand these stroke mimics because lots of questions will be asked during a stroke alert, trying to identify whether or not we can rule in or rule out stroke or a stroke mimic. Hypoglycemia can be quickly assessed on the unit when a stroke alert is being activated. and we can quickly rule it out as a cause of the signs and symptoms and treat it before exposing the patient to multiple CT scans and in contrast. While it's important to understand that stroke mimics do exist, the most time-sensitive diagnosis of all these is stroke. So it's important to activate rapid response and potentially a stroke alert to rule in or out any time-sensitive stroke interventions. Just to name a few, some of these common stroke mimics that we see often on the neuro floors include seizure, sepsis or infection, toxic or metabolic causes, things like new medications, sedating medications, acute confused state, dementia. As you can see, there are quite a few here for you to read through. So what do we look for and assess on our patients to help us determine if we need to activate rapid response for a potential stroke alert? BFAST is the stroke alert sign and symptom acronym. We use this to teach our in-house or in-hospital staff signs and symptoms to look for in order to activate a stroke alert, in addition to teaching our patients and families how to recognize these stroke symptoms and when they're home to call 911 if they do recognize them. You can see any one of these BFAST signs and symptoms by themselves or in combination together. Again, it depends on where the bleeding's happening in the brain in hemorrhagic strokes or where the blood vessel is blocked in ischemic strokes that will lead to specific signs and symptoms. All these signs and symptoms will be sudden onset. They won't be chronic problems getting worse over months or years. For example, when we talk about E for eyes, this is not where I need to go to the eye doctor because my vision's been slowly getting worse and I probably need a new prescription. An example of this would be if you were watching TV and all of a sudden part of the TV goes away, so loss of vision, or all of a sudden there's double vision or blurry vision, not a chronic problem that's getting worse over months or years. When you talk about BFAST signs and symptoms and educate your stroke patients and their families, they will likely relay their story to you about how the signs and symptoms came on so suddenly and the patients were totally normal 1 minute and having those BFAST signs and symptoms the next minute. So let's review each of these BFAST signs and symptoms. B is for balance, sudden loss of balance. This does include things like dizziness. E is for eyes. This can be sudden vision changes such as sudden onset double or blurry vision, gaze preference, gaze deviations, unequal pupils, or disconjugate gaze. Remember, sudden onset symptoms. F, some patients have unequal pupils as a baseline, so it's important if you notice that to try and establish with family if that's something that they've had in the past. F is for facial drooping. A stands for arm or leg weakness, either the arm or the leg or both the arm and the leg. S is for speech. This is going to be slurred, garbled speech, or aphasia, expressive aphasia, receptive aphasia, or both of them together. T stands for two things, time, which includes activating emergency response immediately. When educating our patients, we're going to instruct them to call 911 right away. For you in the hospital, we're going to activate rapid response team. And the rapid response nurse will come to the bedside to assess the patient and get a baseline story before determining if a stroke alert is necessary. The second T stands for terrible headache. This is a sudden onset terrible headache that comes on totally out of the blue. It's not going to be a gradual headache that comes on slowly, gets worse over time. We typically also see other signs and symptoms with this, including nausea, vomiting, and hypertension. So you've noticed sudden onset, BFAST stroke signs and symptoms for your patient. What are you going to do next? Activate emergency response by vocering rapid response team. Our goal is to have rapid response activated within 5 minutes of stroke symptom recognition. Great job noticing those BFAST signs and symptoms and vociferating rapid response to come to the bedside to assess. While you're waiting for rapid response to come to the bedside, you should definitely let your charge nurse know what's going on if they aren't aware already. You'll want to think back to the last time that you saw the patient at their baseline or the last known well time. Think back, was this when you did shift change assessment at the bedside with the off-going nurse? What are the signs and symptoms that you've identified from BFAST that are causing you concern to activate rapid response team? These are a couple of the main things that we're going to ask when we come to the bedside because they're so important in that time-sensitive decision making for things like TNK or thrombectomy for these patients. The bedside shift change handoff can be critical in these situations because you got a chance to evaluate that patient with the off-going nurse to say that this was their baseline and now you've noticed the change. Think back to what time you would have seen that patient with the off-going nurse. If rapid response comes to the bedside and you give them the information and they let you know that we're going to activate a stroke alert, we need to call the code line at 43666 and provide the unit, the room number, and the medical record number for the patient. At this point, we're going to need some help to delegate some of the tasks that need to be done to prepare your patient for CT scan. Things that can be delegated include paging the primary team to come to the bedside. Please do not use Epic Chat even if the team has been communicating with you in real time. Please page the team as this is an emergency and we'll need them to come to the bedside to place orders and to update the stroke team about the patient's current hospitalization, medications, and any other pertinent information. You can also delegate collecting and reporting off of blood sugar. We're going to also need a transport monitor, including all the necessary monitoring equipment to monitor the patient's EKG, their blood pressure, their pulse ox during transport and in CT scan. Other things to prepare the patient for transport include removing the sequential compression devices or intermittent pneumatic devices, SCDs or IPDs, holding IV fluids or tube feedings as appropriate, and getting the patient ready, removing any extra pillows, providing an oxygen tank if the patients needed oxygen. As the bedside nurse, you'll want to prepare to accompany the patient to CT. Please do not just send any nurse with the patient. The stroke team is really going to want to ask the bedside nurse who assessed the patient about the last known well time, any signs and symptoms that they've noticed, new medications, other signs and symptoms like have they been throwing up recently, or other questions that they may have for the nurse who's taking care of the patient. The bedside nurse can help provide all of that information in real time while we're trying to determine patients' eligibility for any stroke intervention. Just a reminder, the computer is no replacement for the team providing the patient's care and their knowledge about that person. To really be clear about when we should be using Epic Chat, I just want to re-emphasize that a stroke alert is a medical emergency, and we should not be using Epic Chat for emergency response. Any patient situations that need immediate attention and require real-time action should have a page going to the primary care team, primary providers, so they can be present to make real-time decisions about what needs to happen for the best care for their patient. Epic Chat is totally fine to use for routine communications, FYIs, and other important issues that may need timely attention, but not immediate decision making or response. Just to be full picture here, by the end of the stroke alert, we should be determining right away whether or not the patient is a candidate for a thrombolytic medication, TNK, a mechanical thrombectomy because they have a large vessel occlusion, or if the patient has intracerebral hemorrhage and what intervention should be starting with that. There may be additional recommendations that are provided by the stroke team after the stroke alert is over, but before the patient returns to the unit, we should be making a decision about any of those 3 immediate interventions for a patient. The next thing that we're going to cover on our stroke med tele skills checkoffs is certification of stroke programs. The Joint Commission is a certifying body who evaluates our program here at UC Davis to determine if we meet criteria as a stroke program. They're going to review specific measures that help us to provide the best standard of care for our stroke patients. The Joint Commission comes to recertify our program every 2 years. The last time that they came was January of 2025, so they should be back sometime around January 2027. And every year in between their visits, we have a call with them to double check with how our program's going and make sure that we're providing the best care to our stroke patients as possible. The Joint Commission offers 4 different types of certifications for stroke programs. Each type of certification builds on the previous level. For example, a comprehensive stroke center includes all the measures for the prior 3 levels of certification. So as a comprehensive center, we do all the measures for acute stroke ready hospitals, primary stroke hospitals, and thrombectomy capable centers. Then there are additional requirements for us as comprehensive stroke centers. You can review some of the main components of each stroke centers on the slide. We here at UC Davis have been certified by the Joint Commission as a comprehensive stroke center since 2020. You might be thinking, why does a Joint Commission certification matter to me? How does it affect the care that I provide to the stroke patients? The Joint Commission provides standards to guide us in giving the best care to our stroke patients. It helps us in how to educate our staff and how our staff educate patients about stroke. This shows our community that we are invested in providing the highest level of care for our stroke patients. What comprehensive stroke measures should you know about as a bedside nurse? Understanding these measures and why they're important will help you prevent complications for your patient and help you to provide the best standard of care. There are 3 main components for Joint Commission that are important to you as the bedside nurse. These include intermittent pneumatic devices, IPDs, also known as sequential compressive devices or SCDs, swallow screens, and patient and family education. Intermittent pneumatic devices, IPDs, or sequential compression devices, SCDs, need to be placed as ordered for both hemorrhagic and ischemic stroke patients, unless there is a physician order to hold or not place the IPDs or the patient refuses. Both of these reasons need to be documented as an order in the example where the physician deems that it's not appropriate for the patient, or as in the flow sheet where the patient refuses to wear their IPDs. Chemical or DVT prophylaxis like subcutaneous Lovenox or subcutaneous heparin is not sufficient to defer IPDs. Depending on the etiology of stroke and the deficits after a stroke, these patients may be at higher likelihood of developing clots due to hypercoagulable states or limited mobility. So please understand that if the IPDs are not on the patient, we may follow up with you about this, unless there's a physician order not to have the IPDs on or there's documentation that the patient has refused them. The next Joint Commission measure that we're going to talk about that's really important for you as the bedside nurse is a swallow evaluation. Patients who have had a stroke may have an impaired ability to swallow. This puts them at risk for aspiration pneumonia, leading to long-term complications, including longer hospital stays, and impairs their recovery from stroke because they're not able to participate with therapy. Swallowing is a really complicated process. It requires 25 pairs of muscle groups to coordinate one swallow. So if even one of these muscles is affected by the stroke, your patient can be at risk for aspiration. So what do you do about this? Make sure that your patient has had a bedside RN swallow screen completed and documented. If the patient fails the screen, do not administer any oral medications, food, or drink until evaluated by speech therapy. Please make sure to follow the speech therapy recommendations closely in order to help prevent this complication from stroke. When your patient arrives from the ED or is transferred out of the ICU, before providing any oral medications or diet, ensure that a bedside swallow screen or speech therapy evaluation has been completed and documented. The RN bedside swallow screen can be found in the flow sheet under stroke swallow evaluation, and the speech language pathology swallow evaluation can be found under the notes. It is possible that your patient may have complications from their stroke, which can alter their mentation or ability to swallow later in their hospital stay. This may warrant another swallow evaluation by you as the bedside nurse or reevaluation by speech therapy. If you have any concerns about the patient's swallowing abilities, don't hesitate to rescreen them and ask the providers for help to reorder a speech therapy consult as needed. Aspiration pneumonia can present serious complications for stroke patients. In severe cases, it can lead to intubation and set a patient back significantly in their recovery from stroke. Please remember to follow carefully the speech therapist's instructions for giving medications and trust in your assessment skills to determine if a patient needs to be rescreened for safe swallow. The last comprehensive stroke measure we're going to review is how to teach our families and patients about stroke. What do we need to teach them about? What are their modifiable risk factors? We'll go on to review that on the next couple slides. Teaching patients and their families about stroke, modifiable risk factors, and BFAST might seem really daunting at first. But remember, we're already doing this throughout our shifts already. It all starts with the care plan and the education assessment. If a patient isn't appropriate to receive education due to comprehension, alertness, forgetfulness, aphasia, or any number of reasons, identify who might be the primary caregiver or support person for that patient. Once you've identified their support person, when appropriate, you'll want to teach on the type of stroke, modifiable risk factors for the patient, and BFAST, sign and symptoms, stroke sign and symptom recognition, and how to activate emergency response. You don't need to cover every one of these items every shift, but you should cover at least one of these items per shift. Throughout this teaching, you have already learned on the types of strokes and BFAST signs and symptoms. Don't forget to emphasize that for patients and families recognizing those BFAST signs and symptoms, they will be calling 911 to get help right away. So let's talk about the last and probably most important education component for these patients, and that's modifiable risk factors. These are so important in helping patients and families understand how to prevent a stroke for them in the future. There are many things that people can do to help lower their chances of having a stroke in the future. Some of the modifiable risk factors, and you can see more listed here, include hypertension, atrial fibrillation, smoking, obesity, diet and exercise, diabetes, heavy alcohol use, high cholesterol, obstructive sleep apnea, drug use, coronary artery disease, and other heart disease. Non-modifiable risk factors, which we can mention to patients, but we aren't really able to teach on these because there's not much we can do about them. Things like gender, race, age, and family history. So how do you teach about modifiable risk factors? Consider your education assessment. Does your patient do best with written materials, or are they an auditory learner? Has their primary mode of learning been affected by their stroke? Like, are they having receptive aphasia? You can talk about how the patient can manage their modifiable risk factors and take control by checking their blood sugar or blood pressures at home. You can also talk to them about medications that they are on for stroke prevention. For example, patients with atrial fibrillation and ischemic stroke, anticoagulation is very important to prevent a stroke in the future. Ensuring patients understand not to miss any doses unless instructed by a provider can be critical to help them prevent an ischemic stroke from AFib. When we educate patients and their families, many times they don't understand why they are taking a certain medication. So that's always an easy place to start. Can lead to a conversation or more information on how to manage the modifiable risk factors such as hypertension. And that's it. Thank you so much for your time today. I really appreciate all your time, energy, and efforts in taking care of our stroke patients and providing the best care for them to help prevent any complications or future strokes for them. Here you can see a QR code where you'll need to scan it and attest that you have completed this module. Remember, you'll finish the stroke skills checklist during your skills J's in January, where we'll review NIH neuro assessment basics, as well as documentation for education and neuro assessment. Thanks again for your time.